It's obviously a pivotal time in our country's history as we think about healthcare and how we pay for it and how we deliver it. And so I've been doing these events around the country in different communities to help people in the church understand kind of the impact of this bill and how it will change how you're experiencing healthcare, how you're experiencing insurance. So what are we going to cover today? We're going to try to cover how reform affects you, and how you're going to access coverage, and a few bits and pieces about how this is changing Everence's role, and how we hope to continue to serve the church in new ways. I'll just say up front that I'm going to be focused on the insurance aspects of this bill. This bill is a very large bill. Only a small portion of it is related to insurance. That's the parts that we hear a lot about, and probably the most about. But a lot of this bill is about how we deliver healthcare in this country as well. I'm not a clinician. I'm not a medical person. I'm from the insurance industry. And so I'm not going to focus on the medical delivery aspects of this bill, but I'm going to focus on how we pay for it, basically. So let's dive in. And first, a bit about Everence. You're aware that Everence has offered health insurance for over 60 years. So we have a very keen interest in these changes and in this bill, and how we're adapting to this changing environment. But what you may or may not know, based on how you've experienced us, is that Everence is a much broader organization. We are, in addition to insurance, we're involved in financial planning, investments, banking, and charitable giving services across the church. So we've continued to expand over the years and change and adapt to a changing church and a changing culture. And this is one of those steps in that evolutionary process where we're adapting again to a new and different environment. So how many of you have read the healthcare bill? All right. This I haven't actually read all 2,000 pages either. I've read a lot of it, and I've spent a lot of time studying it, and that's why I'm here today. But this is half funny and half real. It has been a very complicated bill, and even though it's been 3 years since this bill has passed, it's required a fair amount of time to understand the implications and the interpretations of this bill. So a lot of energy consumed in working on this process in the last while. But in order to dive into this bill and understand where we're going, I think it's important to understand the context of why we're changing, why the changes are happening today, why now, and why the magnitude of change that we're experiencing in healthcare and healthcare delivery and payment. So the main, as in a lot of other aspects in life, a lot of this comes down to cost. This little graphic shows you the percent of gross domestic product that is currently spent on healthcare costs in our country. So GDP, gross domestic product, is the total spend, the total dollars that we spend in our economy, and this is trying to represent not necessarily, it's an aggregate of what we spend as individuals, what the government spends, what the collective total of what we spend on healthcare is in the United States. So you can see in this graphic that in 1980 we were at 9.1% of GDP. That's risen to 20% in 2013 and projected to go as high as 25, or I've seen numbers as high as 40 if you look out on the pace of growth that we're on today. Now, it doesn't take a budget analyst or a rocket scientist to figure out that that's a lot of money, and it's probably not a sustainable growth pattern if you think about all of the other things that we want to spend money on in this country. And so change is coming our way. Now, we might think that that's a worthwhile thing to spend money on if we were getting tremendous results. And the reality is, though, that the United States pays twice as much as a percentage of GDP than any other country in the world for healthcare. And at the same time, we aren't necessarily getting better results than the rest of the world. We rank in life expectancy, we rank 42nd currently in the world, behind countries like Chile and Cuba. You might find that surprising. Our infant mortality rates are actually higher than the entire industrialized world. So we're spending a lot of money, and in some aspects we're getting great results, but there's a wide variety of how healthcare is delivered, and the average results put us at actually a fairly unsuccessful point in the total success of our health delivery system. So why are these costs so high? There's a variety of reasons, but there's the three I'll point out. The uninsured population, currently there's about 15% of the uninsured population. Care has to be delivered at some level. It's not necessarily at the equal levels across the whole system, but care is delivered to uninsured populations, and those costs are costs that the delivery system incurs. So those costs have to be shifted to those who have insurance. Another cost issue is utilization. The amount of service utilization is an industry term simply to identify the amount of care we receive and experience in our society. So utilization has actually been increasing as capacity to solve problems has increased. And so we're continuing to deliver more and more care. There's costs attached to those procedures. And there's a significant issue with chronic conditions in our society, that a large number of chronic conditions that need to be maintained, and they require consistent care, and that's a status of our population base. Now you might one interesting statistic you might find, we have 7,000 people hitting age 65 every day for the next 17 years. So if you think about the total spend we have today and the chronic conditions we're dealing with, as the population ages, that's not going to get better, that's going to get worse, because we have a significant bubble of folks reaching those years where they consume more healthcare. So that's a significant challenge. In addition, new technology, we're adapting to new technologies, and we're able to do things that were not possible in prior generations. But one of the interesting things about healthcare is that in many industries, technology drives down cost. Think about the first computer you bought and what it was capable of, and the last computer you bought and what the costs and capabilities are. Dramatic improvement in cost for results. In healthcare, technology has not necessarily driven down costs. We can do far more, but the costs continue to rise. Now, unless you haven't paid a lot of attention to the political arena, you may have heard that we have a small budget problem in this country, and we're struggling with how to solve our budget problem. Now, I thought I'd get a laugh at that, a small budget issue, and a little bit of disagreement about how to solve that. But what you may not realize is that underlying this healthcare bill is really a critical aspect of paying for healthcare is a critical aspect of our total federal budget. In fact, if we can't solve the escalation of costs in healthcare that the federal government pays, and they are the number one payer currently, even before the implementation of this bill, they're the number one payer for healthcare services. If we can't solve this escalation, we don't have a solution for our federal budget issues. So what's really driving this at this point in time is a recognition that if we don't solve this healthcare spend escalation, that we aren't going to solve our federal budget spending issues either. So I've done a fairly simple little graphic here for you. I've oversimplified the federal budget, but Medicare, Medicaid, and CHIP, which is the healthcare program for uninsured children, it currently makes up 21% of the total federal budget spend. Other major aspects: Social Security is 20.4, interest on the debt 5.7, and national defense at 20.1, leaving a total for all of the other things the federal government does of 32.8% of the federal budget. So as you think about that growth curve that I was talking about earlier with percent of GDP, as the government's percent of spending rises with this aging population base, if we don't solve that, it's going to consume a bigger and bigger piece of this 32.8%, which is all of the other things we do, which is where most of the focus has been on cuts up to this point. So we could almost cut out all of those things and not solve our budget problem if we don't reduce this escalation of healthcare spending. So rising costs and budget challenges bring us to this point in time, and really kind of set the context for why we're facing the challenges we are, and why you're seeing um, uh, some movement to step up and try to find a solution to this. Whether we like the solution or not, regardless of what your position is on that, I think most people are in agreement that we have a spending problem, and we have a escalation of cost problem that needs to be addressed. And we have a bill that's attempting to do that, and now time will tell how well it solves that problem. So based on all those factors, this bill was passed almost 4 years ago now, and obviously there were a lot of legal challenges and delays in implementation, which has actually compounded some of the implementation today. But the Supreme Court last summer ruled that the bill is constitutional, or the key aspects of it are. And so PPACA, or Pension Protection Affordable Care Act, is moving forward and towards implementation. Now, whenever you write a bill like this, they write the general concept into the bill, and then they say, or they delegate to the agencies to figure out how to make it all work. So in the midst of the political vacuum, or the lack of clarity about moving forward, there were delays in the clarity of how this bill is going to be implemented. But over time, Department of Labor, Health and Human Services, and the Internal Revenue Service have had to write the rules and figure out how they're going to talk to each other and how they're going to interpret and navigate this. So the insurance industry and the healthcare industry has been kind of waiting for clarity about all these details, and that's why it's taken so long to move into this implementation, and why there are things that aren't finished yet at this point in time. Now, there are two major pieces of the bill that are still being worked out. The exchanges, which are the marketplaces that you've heard about. We'll talk more about those in detail a little bit later. And then the other piece that is still being fleshed out is the Medicaid expansion. Now, the Supreme Court ruled that the individual mandate was constitutional. That piece of the bill is moving forward. What the Supreme Court didn't agree with was that the federal government could require every state to expand Medicaid access to 133% of the federal poverty level. The bill was designed to pick up payment for services and tax credits and such from that 133% up to 400%. Now, some states have opted to say we're not going to expand Medicaid, and there's a wide variety of where Medicaid coverage begins. In some states, it's as low as 20 or 30% of the federal poverty level. In other states, it's 100%. So the hope was in this bill that they would expand Medicaid to a constant 133% of the federal poverty level, and then we deal with how do we cover healthcare expenses from that point up. So we have a bit of gray and a bit of confusion yet now as to whether or not, depending on the state you're in, about whether there will be gaps in coverage for folks that are below that 133% and somewhere above the access point to Medicaid. Depending on your state, the rules are different, and some states are saying no, some states are saying not now, but we may do it next year. So you'll want to pay attention to your state's specific situation and what that might mean for your community. Now, obviously, Everence, as a part of Mennonite Church USA, has taken a position over the course of the past few years that we're focused on whether we like this bill or not, whether we think it's perfect or not. Our focus has been on supporting the concept of access and affordability of care for everyone. So we recognize that there's wide diversity of opinion about this bill and about how we deliver healthcare in this country. But our organization has focused on supporting the concept of access and affordability, and trying to work then I've taken the approach of attempting to help people understand the bill and understand the legislation, rather than trying to take a political position on this. So you won't hear me take political positions today. We're simply trying to help you understand how to understand the bill and navigate this transitional process. So let's dive into the actual nuts and bolts of this bill. There are a fairly large number of items that were already implemented in the bill prior to 2014. Some of the major changes happened at the end of this year, but over the course of the last 3 years, several details were implemented that are fairly significant. The first one is that generally speaking, if you have children up to the age of 26 that are not eligible for an employer plan on their own employer, that they're eligible to stay on your plan as primary insured. Now, that may not sound real significant depending on where you're at in life, but as someone who has a couple of 20-something kids, it's a nice thing to know that I can keep my 21-year-old, 22-year-old on the plan, and that they can access coverage. They tend to, that age, they tend to not think that they need coverage, but when they actually find themselves in a major medical situation, parents tend to think that they need to step in and help. So this has been a significant positive for many families. They're able to maintain young people on their plan up to age 26 when hopefully they're established and into a career where they have access to their own care and are willing to pay for that care. The bill required insurance carriers to cover any pre-existing condition for people 19 and younger. That was a new expansion of healthcare access in early parts of the implementation of this bill. Currently, carriers can exclude pre-existing conditions on adults, but that will change effective 1/1/2014. Plans can't put lifetime limits on benefits, and the bill also tightened up on annual limits. So when you hit certain points in the past of a total exposure over a lifetime of a contract, whether that's 2 million, 5 million, that sounds like a lot of money, but it happens. Your coverage could run out, and those aspects are no longer legal. Other mandates involve preventative services. Most preventative services now must be included at no copay if you're on a health plan. So the focus again is on proactive, positive health care, trying to prevent costs in the future, and taking away some of the cost sharing obstacles to getting preventative care. One that you may not have a lot of interest in, but insurance carriers have a lot of interest in, is this concept of medical loss ratio limitations. This was a change that happened in 2011. What that really says is that of the premiums you pay, 80% or 85%, depending on the type of plan, has to be spent on delivering actual health care. So what that really means is that the carrier has 15 or 20% of the premiums to cover all their overhead, administrative expenses, profit, whatever, all the other things that go along with delivering an insurance product. So what it's really required is a very, very efficient environment and very low margins, and we think that that's going to drive down insurance costs over time, and that's one of the assumptions that's made in this bill. So those are all things that have already happened. Now let's focus on what's coming, because in 2014, January of this coming year is the point where all the balance of the bill is implemented, and there's some pretty substantive changes here, and we'll spend most of our time now focused on these changes. Mandating coverage, that's the individual mandate was the most contentious part of this bill. Requiring people to purchase health insurance or charging them a tax penalty if they choose not to purchase coverage. If you require people to purchase coverage or purchase anything, you have to figure out a way to means test that, because not everybody has the same capacity to pay. So there are tax credits available for people to help them pay for this coverage, depending on income levels. Purchasing through public exchanges in order to access those tax credits. We'll talk a bit more about that as well. And then guaranteed issue and pricing controls. So guaranteed issue simply means that all plans after 1/1/2014 will be guarantee issue, meaning you can't be denied coverage regardless of what condition you might have or what kind of claims history you have. And pricing is going to be regulated as to how carriers can rate different people based on their subgroups and how they'll price those plans. So we will drill down into each of these areas a bit and add a little more color to that. So as I said, the most contentious part of the healthcare reform bill was the individual mandate. This requirement that if you live in this country, unless you have certain exemptions, that you're required to purchase health insurance. So It's a bit like, think about the fact that if you own a car and you drive a car, you're expected to have liability insurance. It's a requirement. That's a bit of the thinking that's used to expand this. The assumption here is that everyone needs health care at some point in time. And so finding a way to make sure that they're in the system, then they have the means to pay is a requirement under this bill. Now, if you don't purchase coverage, if you don't own coverage, then you're going to pay a tax penalty. So it's a bit of the carrot and the stick approach here. The penalties start out relatively small. In 2014, the penalty is $95 per adult, $47.50 per child, and up to 1% of adjusted gross income, whichever is greater. Okay, so that's not a lot. The total exposure there is about $285 because there's a cap of 4 per household per tax filing. So it's a relatively small penalty, but that then grows in year 2 and 3, and by year 3 you're up to $695 per adult for $347.50 per child, with a maximum of $2,085 or 2.5% of adjusted gross income if you choose not to purchase coverage. So it's a penalty if you choose not to buy, and there will be methods for the IRS to know whether or not you're covered, and it'll be a charge that you'll pay as you true up your taxes each year. So the tax code just got a little bit more complicated. Now, as I said earlier, if you require people to buy something, and not everyone has the same means to purchase, and your goal is to get everyone into the system, then you've got to find ways to provide subsidy for those who don't have the means to purchase. So a system was created to offer tax subsidies, refundable tax credits for people between 133 and 400% of the federal poverty level. Remember I talked about Medicaid expansion up to that 133, and then which would be basically free access to health care at that point. And then you're going to pay from 133 to 400, but on a sliding scale basis to allow you to help you cover those costs. Now, the tax credit is based on what we call an expected family contribution. So at 133%, the 3% of income is targeted as what a person at that level should be able to pay for health insurance, which is not a large amount. And on a sliding scale up to the 400% level, the assumption is you can pay up to 9.5% of your income for health insurance. So these tax credits then are designed to give you a refundable credit to drive down the cost of coverage to that level. Now, in order to receive a tax credit, though, you're going to have to purchase through the public exchange, and you're going to have to buy a silver plan or better, and we'll talk a little more about what those mean. So you can't just go out and buy any plan you want and get a tax credit. You have to buy a plan that's a regulated plan that meets certain requirements. Now let's take a look at a couple of examples, because this is often an area that people have a keen interest in and how this is going to work. So this example is a family of 4. They are at 150% of the federal poverty level, which in 2014 will be $35,137. Not a huge income for a family of 4 if you think about all the demands for a family. Estimated insurance costs for that family of 4 in 2014 on the public exchange, and this is a forecast at this point, is somewhere around $15,831. So you can see that's about 40% of their current adjusted gross income, which is not very affordable. And if a family in that particular situation were forced to choose between spending $15,000 on health insurance or paying for rent, utilities, food, we know that that's a family that's highly likely to be uninsured in this environment. So the expected family contribution in that particular case at 150% is 4%, $1,405, which leaves an estimated tax subsidy of over $14,000. So their net cost for health insurance is really relatively low, and this is kind of the demographic that is going to get the largest subsidies, and they're also the demographic that's currently the most likely to be uninsured. This is based on a 48-year-old head of household, that has nothing to do with the poverty level. It has to do, though, with the cost of insurance. So let's look at another example. Here we have a single individual that's making $34,516. That's almost the same income, but it's a single person, which means that puts them at 300% of the federal poverty level, because it obviously costs less to support one in a household than four. Estimated insurance costs for this 40-year-old single individual is $4,500. Expected family contribution at that point is 9.5%, $3,279, which leaves an estimated tax subsidy of $1,221. So you can see on this sliding scale basis that the tax credits are very significant at the lower end of the income range, and they scale down very quickly as you get closer to that 300 or 400% of the federal poverty level. But these subsidies they're refundable. So when you sign up for coverage through the public exchange, the way this will work actually is the tax credit will be transferred to the carrier that you choose. So the insured doesn't get the cash, they get the subsidy to the carrier to make sure they have coverage, and then they'll pay the difference, and there'll be a true up at the end of the year when you actually file your tax return, because you're basing it on forecasted income, not actual income. So like all the other tax details that we work on, we make adjustments and assumptions throughout the year, and then you do a true up the following year in April. Now, I said earlier that you'll have to purchase on the public exchange in your state in order to be eligible for tax credits. Public exchange, think of it a bit like an electronic marketplace. The goal of this is simplification to purchase the product, but also simplification in the sense that designed to help you compare one product to the next for kind of an apples to apples benefit comparison. So all of the plans will be forced to identify what they call the actuarial value, and that'll a silver plan, which is the minimum requirement to get a tax credit, is considered an 80% actuarial value plan. That means that it's going to cover 80% of the total cost of expected cost of healthcare through copays, deductibles, so between your premium and your copays, you're gonna pay 20%, and the insurance carrier is gonna pay 80%. Now, there are also gold and platinum plans. There are bronze plans, so you can buy other plans, you can buy better plans, but your tax credit is going to be based on the cost of that second lowest silver plan available in your state on the public exchange. Now, the individual states are all deciding whether or not to run their own exchange, whether to let the federal government run an exchange, or to do it as a joint venture. Many states have opted to let the federal government do it. It's one of those ways of simply saying, it's not my problem, and letting the federal government take over. So if you're in Indiana, Ohio, Pennsylvania, Virginia, Florida, Kansas, Nebraska, many of the states that some of you are probably from, those will be federal exchanges, but they will be state specific to your state, and carriers will decide whether they want to be on the exchange in your state. Now, access to the federal exchange or to the public exchange is going to be limited to people who don't have access to employer coverage, or that coverage is not affordable, or they meet certain income requirements. So it won't be open to everyone. And in fact, I would suggest to you that there's really no good reason to go to the public exchange unless you're going to be eligible for tax credits, because the public exchange will likely be more expensive than off-exchange products. And there's a variety of reasons for that, but initially there's going to be some adverse selection because you're going to get a lower income population and a group of people who may not have had access to health care regularly in the past years. So we expect that the public exchanges will actually be more expensive in the early years, and that will even out over time. So if you don't think you're going to be eligible for tax credits, and there are some easy ways to check that, you're probably not going to want to buy on the public exchange, but there will be other vehicles to access coverage. Now, if think about the purchasing process a little bit like TurboTax. Some people have compared that to like Expedia, buying an airline ticket online. Purchasing health insurance is a little more complicated than buying an airline ticket, but there will. I use TurboTax for my taxes. There's this long string of questions. What's your income? Kind of what kind of deductions? What's your family composition? All those kind of details, and then it's going to calculate your eligibility for credits, and then link you up to carriers on the public exchange if that's appropriate. So, in addition to the changes that I've just talked about, the tax implications, there are changes in how pricing of insurance will be calculated. Now, I'm primarily talking about individual health insurance here for folks who are buying on their own outside of an employer coverage. Historically, insurers could look at your health conditions, your family history, your risk level, your age, fairly significant list of things, and they could provide a rate based on what they expected your claims to be. That's really very significantly changed in this bill. There are only three primary things that a carrier can look at when they determine what your cost of insurance is going to be. They can look at age, they can look at geography, and they can look at family composition. Now, age has a direct correlation to healthcare expenses. The reality is, the older we get, the more likely we are to have healthcare issues. But one of the significant changes here that you may find interesting is that currently healthcare insurance costs range from about 5.5 times from the 21-year-old to the 64.5-year-old. So that lowest price person in that age demographic is going to be the 64.5-year-old will pay about 5 or 5.5 times what an individual at that younger age bracket will. The bill requires that a carrier can't charge more than 3 times to an older age person what they charge to the youngest age person. Now, the net effect of that is going to be that young people are going to subsidize older people, if I'm very blunt, because you're going to need the same amount of dollars to pay all the claims that you needed before, but you're just redistributing those dollars. So if you're in those older age brackets, the cost inflation of health insurance up to age 65 is going to be, you're probably going to see potentially some reduction in cost if you're in those older ages. And if you're a 21-year-old male who is the cheapest person today, you're going to see a dramatic increase. So when you see these published numbers of the costs increasing 40%, 50%, typically what you're seeing there is the cost of a young male going up that much, and there's the offsetting balancing effect of the older ages seeing a reduction in cost. Now, you can argue whether that's counter to this desire to get everyone into the system. You can argue that it's not as fair. I guess you could argue that it's even, to some extent, a mutual aid concept. But it's a reality, and I think it will have dramatic impact on the pricing of products as depending on your age demographic. Geography is a little simpler. The cost of care in New York City is higher than the cost of care in Gautsche, Indiana, where I'm from. So a carrier can rate and charge a geographic factor to adjust the pricing of the insurance to reflect the cost of care that you're going to receive in the community you live in. Family composition is simply a family of 5 is going to require more health care than a family of 2. You can adjust depending on the family, the number of people in the household. Now, tobacco use is the only behavioral factor that a carrier can use in rating health insurance. And there's some really pretty punitive factors in this bill. In fact, a carrier can charge 50% more to a tobacco user than they charge to a non-tobacco user in the same demographics. That's a significant number. And the reality, the other factor to keep in mind is that the tax credits will be based on the second lowest price plan without a tobacco rate up. So there's some very, very significant negative impacts for someone who uses tobacco in this bill. We all know that tobacco has a high correlation to health care issues. And so this is one of the proactive ways to try to address that. I find it interesting at times that there are a lot of other behavioral choices we make that have impact on our healthcare costs, and those those are factored out of this bill. But clearly the tobacco industry isn't going to like this bill. Those of you who are women in the group will find that equal rights has arrived in health insurance as well, and you can no longer charge women more than men, which has been the case since the beginning of insurance on health insurance. So no gender-based rating for health insurance going forward. Now, if you're an employer, and I don't know how many of you are thinking from an employer's perspective here, I'll touch on this just a bit. First of all, there are no requirements that a small employer provide health insurance to their employees. A small employer is defined as under 50 employees. There's no mandate that legally requires a small employer to offer coverage. There are some incentives to do that. There are some tax credits available. If you have 25 or fewer employees and the average income of those employees is $50,000 or less, there are some tax credits available to you to help encourage you to continue to maintain coverage for your employees. And the maximum credit is at $25,000 of average income and 10 employees. So you're think about the smallest and the lower income employee base, which are the most likely employers to drop coverage, I think, in this environment. There's some tax credits available for that. It won't cover the cost of care. It won't cover the cost of insurance, but it's an attempt to slow or reduce the number of employers who are going to drop coverage at those smaller levels. Now, larger employers, and again, we define larger employers as 50 or more, do have tax obligations or tax penalties if they choose not to offer coverage to their employees. Okay, this is a fairly complex calculation as well to decide exactly who's qualified, who gets counted in that, and who doesn't get counted in that. But generally, you can take your FTE count, and so if you have a half-time employee, they count half in that equation. And if you total them up and you're over 50, generally you're gonna be required to offer coverage to your employees, or you're gonna pay a tax penalty. Now, these tax penalties are two ways to calculate it. If you offer coverage and you have employees and it's not affordable enough for your employees to participate, because most employers cover part of it and expect employees to cover part of that. So if the employee is got to pay more than 9.5% of their income to access your plan, it's not an affordable plan for them under the law. So if you have a plan and employees choose to go off of your plan and go onto the public exchange, you're going to pay a $3,000 per employee tax penalty for the number of employees that go to the exchange. It's a small number if you think about it in the context of what an employer spends on healthcare, but it's something. If you're over 50 and you choose not to offer a plan to your employees, you're going to pay $2,000 per employee as a tax penalty, because effectively you're putting your employees into the exchange and they're going to be getting tax credits, and it's a way to generate revenue to help fund those tax credits that are going to come back. Now, this part of the bill was scheduled to take effect at the end of this year, along with everything else. And as we all know, this is an evolving story. And just in the last 48 hours, there's an announcement that they're delaying the implementation of the tax penalty piece of this until 2015. Now, as I've been thinking about that in the last day and a half, effectively, I don't think this really changes fundamentally the bill or the impact of the bill. What it does is it delays the reporting requirements for larger employers to get the reporting processes in place, because there's been concern about whether employers would be able to report properly on time by the end of this year because of the delays in clarity that we've been experiencing over the last couple of years. The reality is the bill still requires employers to offer coverage. It still requires employees to have coverage, but it just delays the tax penalties if they don't follow through. The other reality is that of employers with more than 50 employees, 94% of them currently offer coverage to their employees, and so the impact of this is more long-term than short-term, because most employers are not even considering dropping coverage in 2014. They're evaluating the long term, but they're not necessarily considering dropping coverage today. So it is a change. It is an interesting change, but it's I don't think it fundamentally changes the direction we're headed with this bill. Now, employers, you may not be an employer, but you may be an employee of a larger company with 50 or more employees. And one of the terms you may hear if you read in the industry is pay or play. Every employer, the rules have all changed. And so when the rules change, business owners need to rethink their strategy of how they're running their business, how they offer compensation, what kind of benefits they're going to offer. All those factors have changed, and so consequently they have to reevaluate where they want to go with their benefit plans. Pay or play simply means, do I want to pay the penalties or do I want to play by the new rules? And so there's a process that these employers will need to work through, but it's not as simple as the tax penalties I talked about earlier. If you think about it, there's a lot of reasons why an employee chooses to work for an employer. One of the factors is the kind of benefit plans they offer. So the employer is going to have to think about my unique employee base, how many of them would be eligible for tax credits, what kind of income level are they on, can I acquire and retain the talent I need if I don't offer a competitive benefit plan. But there's also some tax consequences for the employee. So if you think about it, if you receive your benefits from your employer, you're receiving a fair amount of compensation tax-free. So if your employer provides you health coverage, that's tax-free income. If the employer chooses to drop that plan and put you out into the market and grow, even if they choose to gross up your income to the point to offset that, you've just now inflated your taxable income significantly, which means they have to actually inflate your income more than the cost of insurance to net that out to allow you to have the same amount of dollars to use to go out and buy insurance. Employers also pay Social Security tax, FICA, on wages, but they don't pay that on benefits. So it's a fairly complex tax calculation for an employer, and employers will be dealing with this over the next couple of years. And I think it'll be an evolution of time as we see the process of employers deciding what to do with this and adapting to a new environment. The fact is, our health delivery system has some illness as well. It has some complexity and some challenges. This is supposed to be funny, and I don't know if you find that funny or not, but the health delivery system is going through a significant change as well. And I'm guessing there's a few physicians in the room, and you may have perspectives on this, but how we deliver healthcare is going to change dramatically in this country over the coming years. And only a couple of comments here. There's a lot of money in this bill for research, pilot projects, increased disclosure on who's getting paid by whom to try to think about where the incentives are in the health delivery system. And then there are significant models emerging for the focus on quality of care versus quantity of care. And if you think about today's healthcare delivery, the more you deliver, the more revenue you generate, likely the more profitable the business of healthcare is. And this bill really is working at changing the economics of healthcare to say you're going to get paid based on outcomes versus based on quantity of care delivered. So that's about as expert as I could be on that topic, just to make you aware of that. But I think the key to bear in mind with that part of this is that's something that will change, and we'll see the results of that over maybe a 10-year period of time. We won't see that change tomorrow, even though things are being implemented. The reason the focus on this bill publicly has been so much on the insurance aspects is that those all change kind of draw a line and the rules change. But healthcare, changing the health of a population, is a long-term proposition. And that's hopefully what we're going to see over the next 10 or 20 years. Now, Everence has been very focused over the years on wellness, and this bill also focuses on wellness and preventative health benefits and health care. We have developed for larger employers programs that provide incentives for employees to care for themselves, to manage their own health care, to stay fit, to manage blood pressure, to stay on their medications, all those kind of things, which we think have long-term payback for employers because you have a healthier employee base. There was some question early on about this bill about whether it would remove your ability to provide some of those positive incentives, financial incentives for employees, and it actually expanded them. So employers have increased latitude to create incentive-based programs where, to oversimplify it, if I'm a participant in the health plan and my weekly contribution, the deduction from my check can be increased or decreased based on how well I do on certain markers and whether I proactively take care of myself. That's a bit of a carrot, it's a bit of a stick as well. But the theory here is that being healthy is not incentive enough for us to take care of ourselves. Sometimes we need financial incentives as well to do that. So just a couple of comments. Some of you may currently be on Everence health plans, our individual and our small group health products. And we did make a difficult decision after a couple year evaluation of this bill to close our individual and small group health lines of business at the end of this year when the Affordable Care Act takes effect. And I think a couple of key points there is that we've been struggling with those product lines for a long time. Participation has shrunk to about 10% of what it was 30 or 40 years ago. Part of that's the advent of, the church that we serve has gone into the public work market, where very few of our people are self-employed anymore. But the reality is that the marketplace to compete has become very, very difficult, and we as a small carrier can't purchase services at the same price that our large competitors do, and that translates into health premiums. The other factor is that, as a faith-based, not-for-profit, member-owned organization, we have to make decisions based on what we think is in our members' best interest. And while we have a lot of infrastructure and a lot of capital investment and people that are focused on delivering health insurance, if we don't believe that we can add material value to you as our members and our owners and the church, then we need to think about making that tough decision to close those lines of business and invest the resources we have into areas that we think we can make a measurable difference and differentiated service to the church. So we made this decision at this point, and we timed that decision to end this year with the opening of new products that will be guaranteed issue. And that wasn't by accident. Obviously, we're very concerned about being able to help all of our members transition to other insurance products, and we know that we would have people on our plans that wouldn't be insurable under the current rules. So while it was a difficult decision, we think it was the right decision, and we think that it will be in our members' financial interests and the church's best interest for us to make that choice. We're not leaving healthcare entirely. We will continue to offer large group, partially self-funded plans for church agencies, for our colleges, for mission agencies, for the denomination, the pastorate plans. We serve a large group of denominational plans across a variety of denominations and self-funded in the self-funded arena, as well as our Medicare supplement product, which this bill doesn't affect negatively at all. And in fact, we think we continue to have a really strong value proposition to serve members with the supplement product for Medicare. So we're very active. We're going to continue in the health insurance business, but these two lines of business are closing. So I'll close with a couple of points here. This is a complex bill. There's a lot of things to understand, and I've spent about 3 years trying to understand it, and I learn new things every day as clarity is given on new topics. So you're going to need to rely on experts. Our advisors are available to help you navigate this, make decisions about where you're going to access care. Our advisors will continue to have access to other carriers and will provide services to help you make choices in that area. So we're not leaving you high and dry there. Also understand that interpretation in this is still in process. This is going to be an evolutionary process, and there's going to be bumps, there's going to be changes, there's going to be some inconveniences along the way. I tend to be an optimist, and I try to stay positive in the midst of these kind of scenarios. And I think that would be a piece of encouragement to you, because when major change happens, no matter how well it's executed, things don't always go exactly like you'd like them to, or anyone would like them to. And I think this bill will continue to be improved. It's going to change. There will be rules changes. There will be an evolutionary process here. Hopefully, and I'm hopeful that 5 years from now, 10 years from now, we're going to look back at this and we're going to have made some positive improvement on the health of the population, and our goal of access and affordability will be advanced for the church and for the community.